Hi, it's Justin Shore from Chronicles of EMS with your 60-second life-saving tip of the day. Today we're going to talk about what to do after you called 911. Well, congratulations on your life-threatening emergency. I'll be there in just a few moments in the ambulance, but before I arrive, I'm going to need your help. Number one, I need to find your house. Make sure your house is numbered and I can see it from the street. 4-inch tall letters should do. And make sure they contrast. Don't put white numbers on a white house or black numbers on a black house. If you can, get a light above it so I can see it at night. Secondly, turn on your porch light so I can see exactly where I'm going. While you're there, unlock the front door or even crack it open a little bit. That'll help us get in safely and securely and help you and your loved ones. Until next time, this is Justin with your 60-second life-saving tip. Welcome to Chronicles of EMS, seat at the table. We're here in San Jose, California, talking about some local issues. As always, our live chat room has a seat at the table. We've got folks from all over the world listening in to our discussion. My name is Justin Shore from Chronicles of EMS.
I'm Mark Blenkhorst, paramedic from the UK and also from Chronicles of EMS.
I'm Bill Sugiyama, EMS Director for the City of Oakland Fire Department and also President-elect for the International Association of EMS Chiefs.
And I'm Mike Tegman, General Manager for Alameda County AMR.
Well, thank you, gentlemen, for being here at the table. One of the things I wanted to talk to you about is Alameda County has some very wonderful community paramedicine type programs going on. Could you speak to that a little bit? What are the practitioners in this county doing that other counties should be following along with?
We kind of started off by focusing on what the community needs were. A little bit different approach than trying to build a community paramedic and then going out and trying to find something for them to do. We instead hooked up with people in the community who really understand what's happening. There's a group called the Ethnic Health Institute, which has got people from all the hospitals, all the community clinics, all the schools of medicine in the surrounding area that really understand the data needs and the issues in the community. And so we really started focusing on those issues. So asthma was really the first one that we've tackled. And we've got paramedics who are training people how to care for their asthma after they've given them treatment in the back of the ambulance. And we're just starting a program. Our folks are all trained. We're just waiting for the IRB to get back on the research study of doing really home visits to do asthma proofing of homes and those kinds of things. So that's been our first big focus. We've got a lot of other things going on.
So it started with asthma. When did it start? When did the folks there realize that they could make a difference and started working on it?
Well, I think some individual paramedics have been doing this for 25, 30 years, just kind of on their own, recognizing needs and providing people with education. I think paramedics all over the place do that, at least ones I ever known with have.
Yeah.
But maybe not necessarily with any science behind it or any official education or those kinds of things. So the program here really got started about a year ago.
Okay, so in 1 year you've gone from kind of taking what practitioners have been doing on their own and we should be doing and moving that into is it system-wide or is it only in some neighborhoods?
In the ambulance asthma education is really system-wide. And it's very brief, teaching people how to use their inhalers and those kinds of things. And then the focus on the home visits, we're focusing on adults who really don't have insurance or other means to get health care. So we're really working with the population around our main county hospital, which sees a ton of asthma patients.
Okay, and are you deploying these home visits? Will that be in a transport resource or like a clinical supervisor, a car or an SUV, or how will that be handled?
They'll probably take an ambulance out because that's what we have, but it's not going to be like an ambulance response.
All right, so obviously not licensed sirens to go do a home visit.
No. It'll be making an appointment ahead of time, and talking with the patient and probably their family as well, and saying, hey, can we come out tomorrow, or when's a good day for you?
Yeah.
We want to help you stay out of the emergency department, and stay out of ambulances.
Now, Mark, that's not something I saw when I went and rode with you in Newcastle, that you guys were doing specifically. It seems like you have other resources for that in your system. Am I correct in thinking that?
Yeah, we don't go out and do like home education visits and stuff. I was curious with what you said about if you have a patient and you treat the asthma in the back and educate them and stuff. Do you still transport or do you leave them at home then?
It's the education usually happens during the transport. So
Right.
you show up, you give somebody a nebulized breathing treatment, and then once their breathing is calmed down, then you can kind of walk them through a questionnaire that we put together about how much you know about your asthma, the medications you take, and really kind of tailor the coaching to what people really need based on their answers to the questions.
Could you ever see it developing into you go out for an exacerbation of asthma and the paramedic takes a nebulizer, treats them, gets them back to their norm and then says you're fine, and then maybe one of the education team comes out and checks up on them later on or anything?
I think evolving to that kind of model makes a lot of sense.
Yeah.
And there are certain diseases that lend themselves to that
Oh,
pretty
very
well.
much so. There's been a huge thing in the UK recently for all COPD, and we're very fortunate in my service that I have access to. If I go out to an exacerbation of COPD patient, I can assess them, treat them, and then either leave them and just you're fine now, or we have a team of nurses from the hospital who we contact and they come out within the next hour and they'll check on them, and then if need be they'll come back 4 hours later or the next day. And there's
a great resource.
There's a big drive about keeping people out of hospital.
Do you still have physicians that will make house calls in the
Yeah,
evening as well?
yeah. But these urgent care team nurses now are our sort of first response, probably better than the GPs because they have the facility to come and check and then come back and check later on and then check on for all minor illnesses. They'll do that.
That's great.
Yeah, I think, the socialistic model in the UK, I think that's where we're evolving into, as you can see here. Because right now, the way things that are occurring here in the United States, and especially examples in Alameda County, what Mike's doing right now is what we need to expand globally and nationally. Because the situation is currently EMS is the Band-Aid for healthcare right now. We are the first response in primary healthcare for those that don't have healthcare. And the avenue and the aspect that Mike is approaching right now is adding on that component and opening up social services for these people to get the care, longevity they need, to keep them out of the hospitals and so forth. That's the major piece that we're missing. So right now still, people are calling 911. Mike shows up, recognizes a problem, opens up his resources, but then where does it go from there? The missing line is at the hospital. Where does it go from there? They see so many people into the EDs. And one of the issues that we're running into, it's like a funnel. Right here we have this funnel with this huge population of people. And right now, as we've seen in the other documents, such as Firestorm, the hospitals are closing down. They're all shutting down because there's just too much demand, not enough money, and everybody's going bankrupt and they're all merging together. So we have this huge funnel of people and we have no resources for them. So the ERs become that Band-Aid for that. And so the breakdown is that the EMS system needs to evolve further, work on, create agreements, and be more operationally sound in that point to where we have a structured environment to where we can open up the avenues to social services to get these people to mitigate any of these disease and illnesses from continually reoccurring and to get them that access.
Could this also be something where the team comes out, treats the asthma, educates, and then leaves them there, follows up the next day, or passes it along to some sort of other clinical program?
I think it certainly can. I think the thing that's important for us to work through, though, is to really develop some science or some evidence behind those possibilities. So one of the things we're doing with our asthma team is we're going to work on people who've been seen 2 or more times in the emergency department at Highland Hospital. And so people who've got significant problems with their asthma and within the last year, and then half of those folks are going to go to the regular asthma clinic in the emergency department. The other half will go to the asthma clinic and then get the home referral. The goal is for us to be able to see whether or not the home visits facilitated by our EMTs and paramedics will decrease emergency department visits in this branch of the study. And the reality is we don't know. It really feels good, sounds good, we've got a lot of excitement around it, but the honest answer is we don't know if it matters yet.
And the worst part could be is you could do this home intervention and make a difference, and they're still going to call 911 because it's going to take 4 days to get in to see a doctor somewhere else.
Especially when you said you were targeting the people who don't have insurance.
Right.
Then 911's still going to be there, access to help. If they have an exacerbation, they're still going to call you, even though they know maybe that it's not an emergency.
Well, we do have universal health care in America. It's called 911.
Yeah.
Yeah.
Exactly.
And I think there was a program a long time ago out of Highland Hospital called Project Respect. And actually, it was a small grant-funded program that lasted for about a year. And what it did was it merged EMS in with the social aspect of social services that was given at Highland Hospital for people that were recognized for that need. The program worked very well. And due to the lack of resources and funding, it just went away. But that's one of the areas, it's that middle piece, it's that piece right there that I believe that we're all missing. It's that connection to avenues of services and so forth. Because all we're doing right now is, Mike, you go out there, you do a great job on all your stuff, and then we transport this patient to the ED. What do? Wham, bam, here's your nebulizer. Hey, good job, see you later. Kick you right out, and they go back home, and they go back into their environment, you know, and then this is just a larger picture. They go back into their community, into their environment that may be a dirty household, something that really fosters their asthma to continue to reoccur, you know. They don't have walkable communities, access to health care, access to good food. And usually what we're running into is those without insurance who live in impoverished communities and don't have those resources and means. And so I think, I mean, we can get on the, you know, kumbaya and get everywhere. I mean, what is ideal is if we can develop communities that can be self-supportive and have those fundamental resources within walkable areas and everything else. I mean, there's a lot of things that unfortunately are occurring, and we are just continually throwing Band-Aid actions at them, I believe, and we're not really resolving issues.
Now, you mentioned you're with the Oakland Fire Department.
Yes, sir.
First response EMS from your department. When these folks go out in these homes and they see these conditions, can they act on those? Do they have referral numbers they can give to people, like, hey, you know, it looks like you need a little bit of help, why don't you call these folks? Not necessarily Adult Protective Services, which is the only number I have in my service, but do the first responders, not just the transport agencies, do they have access to any of the resources in your community?
It's funny because well, it's not really funny, but the situation is we have a 211 number that helps to open up those resources and those access, the access, and we do have the magnets, and our personnel are trained to go ahead and when they recognize those issues to try to involve social services or social workers to get that assistance in. But with the budgetary crisis the way that it is right now, those resources are extremely limited. The wait periods can be very, very long, and also there is so much expected of the individual that has the need or issue. Paperwork, you got to do this, you got to come down here, that it becomes very arduous and they end up giving up on the system because they feel like the system is failing them. So in other words, nothing is easy. Is one of the issues of problem. Nothing is streamlined and nothing is, like, in many ways given for free. So what we do, what's easier, is I fill out 10 pages of paperwork, or I call 911 and have Mike Tagman show up to go ahead and give me a breathing treatment and take me to the hospital. You know, that's what we're running into.
Well, the 211 resources really are, we're starting to use those a lot more. Have you played with 211 at all?
I've called it in the city of San Francisco where I work, and I got an automated system that I couldn't navigate, and I passed that along. I passed that along, and I was told that there's just no budget for operators. I haven't called it in recent years. They also have a 311. There's a 511. There's many numbers, but there's only one that gets you a live operator every time, and a 4-minute response.
That is true. Now, we've had much better luck with 211 recently. I don't know whether they've gotten funding recently, and I think a lot of it depends on where you are geographically. 211's not as proliferated nationwide, and each location has got different levels of resourcing. But the level of information they've got around, you know, hey, I don't have any money, I need to get my clothes washed. Is there a place I can get that done? I've run out of my insulin and I don't get my paycheck until Friday and it's Tuesday, what do I do? I mean, and they have really got the capability to point people to resources that they might have a hard time getting otherwise.
Can I ask a question which may be what makes it interesting for us, that an outsider looking in, and I apologise if it's the wrong question to ask, but when you're talking about your community paramedicine and the things that you're trying to do, from an outsider it sounds like you're trying to do everything that you can for the patient by looking at their environment, increasing their asthma and stuff, but everything apart from letting the medic make the clinical decision about whether they need to travel or whether they're safe to stay at home and things like that. And is that because of the litigation, the funding, it seems to be that everything that you can do safely without risk of anything you're doing. But what stops that final step over
here? The challenge, there's two pieces to it. The first is, it's been a long time since I went to paramedic school, but I did help rewrite the national paramedic curriculum in the U.S.
Yeah.
And there's no module in there about the decision making to decide that somebody's okay not to go to the hospital.
Yeah.
There's no frame of education or reference for that. And I worked when I was consulting before I took this recent job with one EMS system who really wanted to be able to do that better. And we started to put together a curriculum of what kind of education it would take in order to decide if your sore throat, was okay to be seen by the doctor tomorrow, or you needed to go in tonight, or your child's got a fever and cough. Is it the kind of fever and cough that we need to go in and end up with a spinal tap because it might be something associated with meningitis, or is it something that's just a cold and not a problem? The curriculum for how to think through those kinds of things essentially is a PA curriculum,
right,
or a nurse practitioner curriculum. If you look at the base of medical knowledge, physicians, nurses, PAs, they get this big base, and then they go specialize in something high. Those of us in EMS, we don't get much base. We get a ton of specialty.
Yeah.
And since we haven't provided our folks with the tools and education to make those kinds of decisions, I'm reluctant to put that on them, and on their patients, quite frankly.
Yeah.
Until we decide that that's the kind of thing that we're going to pay for and support as a community of people who run organizations.